Hello, everyone. This is Roderick Campbell, and today I will be presenting on racism in healthcare. I chose this topic because I believe it is something that a lot of people would like to sweep under the rug and act as if we as a society have progressed into a nation state that does not consider racism as a factor. These factors include our hiring practices, admissions processes, biases, accesses to healthcare, and disparities in the quality of healthcare that one receives. As a black man in America, I see it as my duty to always represent my race with the most pride and grace that I can. And if that means that I have to discuss and educate others who may be more established and experienced than me in certain areas, then that's what I will do. I'm not afraid to speak my mind, and the fact remains we have a lot more work to do in the United States as it pertains to racism. This topic will be of special interest to me because not only am I a black man in America who experienced this racism that I will be highlighting, but also because I graduated with a minor in African American Studies at Northwestern University. I'm excited to be able to have this platform where I do not feel like I'm preaching to the choir, but educating people who may not be exposed to the situations and nuances I am exposed to. Transitioning into the outline and what I'll be presenting on today. The first thing will be, why is racism a current issue that we have in the United States? Some people may disagree with me, but I will show how and why that racism as it regards to healthcare is a current issue that we have today. And then I will be talking about an article that I came across in my other class, MHA 531, which is A Gardener's Tale by Dr. Jones. She had some really good insight on what racism is, and I think it would be a good introduction to those who aren't aware of the different types of racism. So we have institutionalized, personally mediated, and internalized racism. After that, I will be talking a little bit about the history of racism in healthcare within our country and provide examples with the Tuskegee syphilis study and Henrietta Lacks, who they used for the HeLa cells. After that, I will then transition into the 10 studies that I found from the University of Michigan and use those to highlight the current things that are happening within America that shows the racism and how much further we need to go as a country to eliminate these disparities. And then I will finish with my conclusion and the final thoughts as to where I think we are headed and the things that need to happen to fix these problems. Racism as it regards to healthcare is a current issue because this is the sad reality that we are living in today. I'm not going to spend too much time explaining why it's an issue, but it really affects the psyche of Black people because we feel that there is a mistrust within the healthcare system due to the history, and that transcends how things could be as far as race in healthcare. To start, there is a disproportionate number of people who die from COVID-related deaths in the country. Far more Black and brown people are dying at much higher rates than that of white people. So this is why that's a current issue, because it's an issue that I believe never went away over time. A Gardener's Tale did a great job, in my opinion, of identifying the problems of racism within healthcare. But I feel only brushed the surface of it, especially in terms of how to fix the problem of racial disparities in healthcare. I think The Gardener's Tale was a PG-13 version of what's going on right now and what has transpired since the inception of the United States. And for those who are just becoming aware that there is a problem with race, not only in healthcare, but in the world, this is a great story to read to begin to have a snapshot. And the most important thing that I learned from this article are the three levels of racism that Dr. Jones introduced to us. And the next three slides, I will explain what those are. Dr. Jones defines institutionalized racism as an differential to goods, services, and opportunities of society by race. Institutionalized racism is normative, sometimes legalized, and often manifests as inherited disadvantage. It is structural, having been codified in our institutions of custom, practice, and law, so there not need to be an identifiable perpetrator. Institutionalized racism is often evident as inaction in the face of need and manifests itself both to material conditions and the access of power. Personally mediated racism is defined as prejudice and discrimination, where prejudice means differential assumptions about the abilities, motives, and intentions of others according to their race, and discrimination means differential actions toward others according to their race. Now, personally mediated racism is what most people think of when they hear the word racism. Personally mediated racism can be intentional as well as unintentional, and it includes acts of commission as well as acts of omission. Internalized racism is defined as acceptance by members of the stigmatized races of negative messages about their own abilities and intrinsic worth. It is characterized by their not believing in others who look like them and not believing in themselves. It involves accepting limitations to one's own full humanity, including one's spectrum of dreams, one's right to self-determination, and one's range of allowable self-expression. In other words, it manifests an embracing of whiteness. The Tuskegee syphilis study is a study that a lot of people may or may not know about, but it began in 1932 by the Public Health Service, and they began to study and record the natural history of syphilis in hopes of justifying treatment programs for blacks. The study involved over 600 black men, 399 of those who had syphilis and 201 who did not. And this was all conducted under the assumption that the black men thought they were being treated for what they call bad blood. And in 1947, when there were established rapid treatment centers to treat syphilis, the men in their study were not treated, so therefore they weren't giving the adequate treatment that they needed. So in 1972, there was a hearing that said that this is unethical, and since then there have been reparations, but this shows the history of the mistrust and how it started, not from this study, but how black people have a mistrust of the healthcare system. Henrietta Lacks was a mother of five who visited the Johns Hopkins Hospital and complained of vaginal bleeding. And upon her examination, Dr. Howard Jones discovered a large malignant tumor in her cervix. And at the time, the Johns Hopkins Hospital was the only people to treat African Americans. And as the records show, Dr. Gay, there was a prominent cancer and virus researcher, and he had been collecting cells from all patients who came through the hospital with cervical cancer, but each of the samples died quickly. Henrietta Lacks cells were unlike any of the others he had seen, because where the other cells would die, her cells doubled every 20 to 24 hours. And why this is important, they are called HeLa cells. And this is important because they are used to experiment without having to do so on humans. And they study the effects of toxins, drugs, and other hormones and viruses with the growth of cancer cells. So Henrietta Lacks' contribution to the healthcare system with these HeLa cells are unwarranted because she didn't know that she was unknowingly donating her cells at the hospital. Now that we have a background of why and some examples of racism in healthcare, I'm going to transition to an article that I found which had great studies by Jordan Imhoff, which is a roundup of 10 studies that highlights the health disparities between Black and white Americans. As the article states, there is a startling and disproportionate death rate among Black Americans around the country from COVID-19, and it's revealing persistent inequities and the need for solutions to address them. In Michigan, over 40% of COVID-19 deaths are African Americans, while only 14% of the population is made up of African Americans. I'll repeat that. In Michigan, over 40% of the deaths related to COVID-19 are African Americans, but only 14% of the population is made up of African Americans. This is significant, and the numbers are changing every single day, says Dr. David J. Brown, who is the Assistant Vice President and Associate Dean for Health Equity and Inclusion at Michigan Medicine. For an infectious disease like COVID-19, reducing exposure is key to reducing the infection rate, and many brown and Black people are known to have lower medium incomes, which lessens the chances of an economic cushion during these uncertain times, which leads to many not being afford to not working and are on the front lines in jobs such as grocery clerks, janitors, or bus and train operators, which makes their exposure much higher because of the economic influences that are behind these decisions. It's not about the body itself, but the societal situation in which the body is embedded. According to this study, Black, Hispanic, and Indigenous women are more likely to have gaps in insurance around the time of pregnancy than white women. Nearly half of all Black, Hispanic, and Indigenous women had discontinuous insurance coverage between preconception and after delivering their babies, compared to about a fourth of white women. Spanish-speaking Hispanic women had the lowest rates of steady insurance, with nearly 1 in 10 not being insured at all between preconception and the postpartum period. This study comes as women from racial and ethnic minority backgrounds face greater risk of maternal morbidity, unexpected outcomes of labor and delivery that negatively impact a woman's health, and mortality associated with childbirth. This study explores why prostate cancer mortality is higher in Black men, and the data shows that Black men don't appear to intrinsically and biologically harbor more aggressive disease. It's because they generally get fewer PSA screenings and are more likely to be diagnosed with later stage cancer, and are less likely to have health insurance, have less access to high quality care, and other disparities that can be linked to a lower overall socioeconomic status. So we see that not having access to different resources lead to a higher mortality within a certain population, specifically a Black population, and we have to find out solutions that can help bridge this gap. This article provided me with information that I already suspected, but now can put into words with the proof of studies to go behind this. In today's America, it says minority patients still have markedly worse health outcomes than white patients. The differences are greatest for Black Americans compared to white patients, and they are 2 to 3 times more likely to die from preventable heart disease and stroke. One of the main points of this article shows that building trust is key, and that when Black patients, when they have a Black doctor, there is a certain level of comfortability that occurs there, and Black doctors spend more time writing detailed notes and time together to build the trust within the patient so that they can have better patient perceptions and treatment decisions that affects the patient. What is also prevalent is the continuing mistrust from situations as the Tuskegee syphilis study and Henrietta Lacks that contributes to this lack of trust that minorities may have in white doctors. And the ultimate goal is for everyone to have the best possible health outcomes, regardless of race or ethnicity of patients and doctors. and minority patients should be able to trust their white physicians, and white physicians should be able to take equally good care of minoritized patients. And until structural racism does not exist in the world and in healthcare, minority patients will still feel more comfortable with a minority doctor, but it's hard to find. This study shows that both age and race impact colorectal cancer survival. African Americans diagnosed with colorectal cancer at a young age had a significantly worse outcome compared with young adults who are white or Hispanic. The researchers found that young African Americans with stage 2 colon cancer have a 60 to 70% higher risk of death compared with young white patients, and previous studies have shown disparities are more pronounced in advanced disease. This study highlighted that dying in America is an expensive process, with about 1 in 4 Medicare dollars going to care for people in their last year of life. But for African Americans and Hispanics, the cost of dying is more than it is for whites. The cost of the last 6 months of life is $7,100 more expensive to the Medicare system for blacks and $6,100 more expensive for Hispanics compared with whites, a University of Michigan team found. This article intrigued me because, unlike the other kinds of health cost disparities and differences in patients' income, education, medical conditions, or other individual factors, such as hospice use, it didn't explain the disconnect. And that's interesting because there's an underlying systemic issue here, which is race, which we still don't know why that there's such a disparity, but there is one. How do we find the answer to this? We have to continue to work on that. This study shows a new analysis that identifies long-term hypertension as a possible explanation for why Black people are more likely than white people to develop dementia later in life. The study suggests that Blacks have a higher cumulative blood pressure level that contribute to Black and white differences later in cognitive decline. It is stated that the Michigan medicine researchers analyzed pooled cohort data from more than 19,000 participants over a median flow of up to 12 years. They compared participants' blood pressure levels along with 3 cognitive measures that included global cognition, memory, and executive function. When the researchers adjusted for cumulative mean systolic blood pressure levels, the racial differences in cognitive decline were no longer statistically significant. This study says that it reveals the blind spot in coverage of low vision devices and that there is technology that can enrich the lives of those with low vision, but a Michigan medicine researcher says a policy change might address a racial disparity in device use. Blacks and Hispanics who have trouble seeing are missing out on the technology that can help them read, drive, and stay social. Low vision devices are considered a game changer for the visually impaired, but a University of Michigan Kellogg Eye Center study shows that significant inequality in use of the technology proven to improve functioning and quality of life for older adults. Low vision device users were more likely to be older and white compared to those who did not use the devices. This study consisted of over 3,000 Medicare beneficiaries who were 65 years and older, and the authors found that compared with white individuals, adults from minority racial/ethnic groups were less likely to report using these low vision devices. Since the Affordable Care Act was initiated in 2010, this new study shows that it has narrowed racial and ethnic gaps in access to health insurance and healthcare, but has definitely not eliminated the problem. Black and Hispanic Americans are still less likely than non-Hispanic whites to have health coverage and more likely to avoid care because of cost. This is a current event because we still have over 30 million people in the United States who do not have access to health insurance and health care. This article states that even before COVID-19, many adults lack stable food supply, and food insecurity disparities by age, health status, race, ethnicity, and education, seen a national poll on healthy aging, the pandemic have worsened these. The percentage who said they'd experienced food insecurity in the past year was even higher among those in the pre-Medicare years and those who are African American or Latino. Older adults with lower household incomes and lower levels of education were also more likely to say they had trouble getting food. The disruptions to food supply chains, employment, and social services from COVID-19 may have worsened disparities, says the experts who designed this poll. In conclusion, this research reaffirms that many older adults, especially within the African American community, struggle to afford the food they need, and these are exacerbated by the introduction of the COVID-19 pandemic. I think that this is a pretty good starting point for the current racism issues that we have in the United States today. These 10 studies highlight some of the main problems that we have. And after this video ends, I want you guys to go and check out the article because I think it provides great information and insight on how we can view these problems and what we can do to fix these. Also, these problems are prevalent in the daily thinkings of Black and Brown people because I look at an event such as the COVID vaccine and why Black and Brown people are more or less likely to want to get the vaccine because of the history that we have, which I highlighted in the Tuskegee syphilis study and through people like Henrietta Lacks. And it shouldn't be that way. And I think through education and more people wanting to eliminate these health disparities that we have in America, we will start to make progress. And for me, I look forward to learning how we can all come together to help eliminate these racial disparities, not only in healthcare, but in the world as well. And the quicker that we realize that race is a made up social construct that is used to organize people, I think the quicker we'll be able to empathize with others who do not look like us. And impacting the world in a positive way is a goal that motivates me every day and inspires me to set an example for future Black generations. Healthcare is a great place to make an impact, and with representation, we can provide the playbook to overcome the racial disparities that we see in our country. Here is a list of the references that I used to create this presentation today. I would love if you guys would go and click these links and read the articles and try to come to an understanding for yourselves as I did and be able to present and talk about these situations because it's the only way we'll be able to move forward as a society, as a country, if we are able to be knowledgeable and have conversations like this to realize that racism in healthcare is something that still persists and is still relevant to how business is constructed and how people feel about the healthcare system today. The majority of information that I presented on came from the EMOF article, which was written back in June 3rd of 2020. And I just believe that it has great information as to what the current problems as it regards to race, specifically in healthcare, and some of the solutions that we can have to try to fix this problem. Thank you guys for listening. This is Roderick Campbell again, and hope you have a wonderful day.